Hello, and welcome back. In Chapter 6, we're talking about assessment and a diagnosis of substance-related disorders, SRDs. So, substance-related and addictive disorders are a set of behaviors over which a person demonstrates a lack of ability to control, even in the presence of significant consequences, right? So, substance-related disorders, SRDs, are rampant and can also be fatal. SRDs include both substance use disorders and substance-induced disorders. So the DSM-5 provides criteria for diagnosis of SRDs for alcohol, caffeine, cannabis, hallucinogens, inhalants, opiates, sedative or hypnotics or anxiolytics, stimulants, tobacco, or other unknown substances. Each of these substances share the same general diagnostic criteria. You're going to find that each of them have the same criteria, right? That you have to go through so you can manifest to see if they have a use disorder. But the actual the drug category or the impact that the drug has on the brain, the neural system or whatnot can be different, right? So the DSM-5 specifies that substance-related disorders are characterized by the cluster of cognitive, behavioral, and psychological symptoms indicating that the individual continues using the substance despite significant related problems. So there are three terms that will help you understand the process. Cravings are important. It's that person's urge or desire to actually get there. Tolerance is very important. Have I built such a tolerance for it that I have to use more to actually get um, my desired level of highness. Withdrawal. If I stop using it, am I going through withdrawal symptoms? Am I having physiological symptoms because my body and neural network is searching for those neurotransmitters, and I haven't, and I'm not able to, and I'm not providing those networks to my physiological system. So symptoms of substance-related disorders: impaired control, risky use, social impairment, pharmacological criteria, right? Once symptoms are identified, we determine the severity and the status of the use with the specifiers. So let's talk about gambling disorders. It's diagnosed by one of 9 symptoms: persistent and recurrent problematic gambling, right? In the absence of manic episode, right? So gamble with increased amounts of money to achieve excitement, experiences restlessness or irritability when attempting to reduce or halt gambling, repeatedly attempt to control, reduce, or stop the gambling, spend significant time of thinking of gambles when distressed, attempts to recover losses due to gambling by returning to gambling, lies about the gambling, strains or loses significant relationships or educational or employment career opportunities because of the gambling, and relies on others to pay debt in gambling, right? So a mild includes 4 or 5 of those 9 symptoms being present. A moderate is going to be 6 to 7 of those symptoms being present, and a severe includes 8 to 9 of them being present. So again, you would document how many they meet and how they meet each of those criteria or whatnot. You just can't put that he lies about gambling. No, how did he report? What did the client report that shows you that he lies when he gambles or whatnot, or she gambles or whatnot? So you can actually justify that they met that criteria. So, so why use standardized assessments? Standardized assessment offers several additive benefits to clinical judgment. It results to tell the clinicians if the client has more or less about the same amount of trait as the average person, and they provide objectivity. Assessments are constructed using either the logical method, the criterion method, or the combination of two. Items are logically constructed instruments directly inquire about the amount, frequency, and duration and consequences of the behavior. The criterion keyed method is used to circumvent the defensiveness, right? Its scales are constructed by selecting a target group that possesses the trait of interest, right? The item content does not matter. Any item included on the screen simply is based on the two groups. Decisions to use criterion key screen, uh, a logically derived screen, or a screen that combines with both approaches depending on the purpose of the screening. The sensitivity and specificity. Sensitivity is the ratio of persons corrected screening, right, positive, and having an SRD to those who actually have the disorder. Specificity is the proportion of people that are screened accurately identified as not having the SUD. You're talking about false positives or false negatives. Reliability and validity. Reliability is the consistency of the screen results. Reliability estimates zero point 0.7 or higher are optimal for trait-based screens. Validity is the degree to which a screen accurately assesses that which design is measured. Are you actually measuring what you are attempting to measure in the assessment is validity. Validity estimates that 0.4 or low and estimates of 0.9 or higher. Time and cost efficiency. Some screens, such as those incorporated in large personality assessments, can be expensive. There's other ones that are free that you can actually utilize. There are human labor costs involved in administering, scoring, and interpreting the screen. Other cost factors include financial consequences for making inaccurate assessment decisions. So self-administered standalone assessments. So substance abuse subtle screening inventory for the SASE, right? It's used for substance use screening instrument. The SASE contains 9 empirically established scales. It's the symptoms, the obvious attributes, the subtle attributes, the offensiveness, supplement addiction measure, the family versus controlled subjects, correctional, and prescription drugs. The Michigan Alcohol Screening Test, the MAST, has 25 true or false questions. Individual scores or some individuals' item scores are summed, and the following rubric is used to interpret the results. 0 to 4, not alcohol dependent. 5 to 6, maybe alcohol dependent. 7 or more is alcohol dependent. The Cage is a brief 4-question screen that about our attempt to cut down, being annoyed by others, criticism of drinking, feeling bad or guilty about drinking, or drinking in the morning. 2 or more yes answers are suggested that you have an alcohol use disorder. So alcohol use disorder identification text, right? The audit. This is 10 items are divided to 3 subscales. 3 questions assess the quantity of frequency of alcohol. 3 focuses on alcohol dependence, and 4 tap into the negative consequences of their use. Alcohol use inventory. The AUI is a 228 item tool that assesses clients' perceived benefits, style, consequences, and concerns related to alcohol use. The Additive Severity Index. The Additive Severity Index is a free assessment considered to be the gold standard for SUD treatment, research, and evaluation. Well, this is an addiction severity index, not alcohol, I'm sorry. The ASI serves as a multidimensional tool with application across a wide variety of settings. The TACE. It was the first validated alcohol risk screening instrument developed specifically for pregnant women. It included a question of tolerance, annoyance, efforts to cut down, and eye-opener drink. The Tweak is a 5-instrument development from questions from the MAST, Cage, and the TACE. Has been almost used exclusively to screen risky drinking in pregnant women. The brief biosocial gambling screen is a 3-item self-administered scale based on the DSM-4 criteria. Affirmative response to any items is considered potential gambling related, requiring further evaluation. The early intervention gambling health test. This is the 8th screen was developed as a clinical instrument to identify subclinical pathological gambling. This screen has 8 questions with yes or no response options. 4 or more yes answers indicate probable subclinical or pathological gambling. Gamblers Anonymous 20 questions includes 20 questions with yes or no response options. Positive answers to 7 or more questions may suggest a gambling problem. The National Opinion Research Center DSM screen for gambling problems. The NODS. This is a 34-item questionnaire scored on yes or no responses. Score is on a scale of risk of 1 to 2 items. Problem gambler 3 to 4 items, and pathological gambler 5 to 10 items. The Problems of Gambling Severity Index, the PGSI, contains 9 items with response options ranging from never, which is 0, to almost 3. Scores of 1 to 2 are addictive, indicative of low-level gambling problems. Scores of 3 to 7 are produced by those with moderate gambling problems, and scores of 8 and higher suggest problematic gambling. The South Oaks gambling screen is a 20-item questionnaire with multiple response questions. It's based on the DSM-3 criteria as a clinical instrument and remains the most widely used screen. So, an assessment chapter in addiction is not complete without addressing the behavioral addiction instruments. These are the instruments for hypersexual disorder, internet addiction, and non-suicidal self-injury. Right? Again, because all these things can be related to addiction or whatnot. There is other forms of addiction.